Good afternoon. I'm Kate Ellis, Director of Research Programs at the National Institute for Healthcare Management Foundation. On behalf of NIHCM, thank you for joining us today for this important conversation about private equity in healthcare. Private equity, or PE investment, plays a growing and significant role in the financing of healthcare in the United States. In 2022, it was estimated that nearly 900 healthcare-related service deals were closed by PE firms, after reaching a peak of over 1,000 transactions in 2021. Despite the surge in private equity-related healthcare deals, there is little regulation of private equity investment. And while private equity investment in healthcare may improve operational or technological efficiencies, there are growing concerns about the impact on cost, quality, and utilization of care. Today, we will hear from a prestigious panel of experts to understand more about private equity growth in healthcare. Before we hear from them, I want to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM team who helped to convene today's event. You can also find biographical information for our speakers, along with today's agenda and copies of slides on our website. We also invite you to join the conversation on Twitter using the hashtag #PrivateEquity. I am now pleased to introduce our first speaker, Dr. Atul Gupta, Assistant Professor in the Department of Healthcare Management at the University of Pennsylvania Wharton School. Dr. Gupta's recent study on private equity ownership in nursing homes was cited in the 2022 State of the Union and by subsequent regulations to improve transparency in nursing home ownership. We are honored to have him with us today to share his perspective and expertise. Atul?
Good afternoon, everyone. Thanks to NIHCM for inviting me on this prestigious panel. I'm really excited to be here and to get us started. My talk is really going to be focused on three parts. The first part, I'm going to try and explain in simple words, in as simple words as possible, what private equity is, and sort of set the stage and get everybody on the same page. It's admittedly a complicated concept that took me some time to understand. The second part, I'm just going to give you some facts on the trends in private equity involvement in US healthcare and make the case that private equity has dramatically increased over the last few years. And in the third part, I'll again give my own views and based on the literature and my own reading on why it is the case that private equity has grown its involvement in healthcare and what the implications could be. Next slide, please. So what is private equity? So in the most simplest terms, let's break down this term private equity. So the first word, private, well, private just denotes the fact that when these transactions happen and a private equity firm acquires a stake in a company, that firm is quote unquote taken private. So if that firm happens to be publicly listed on a stock exchange, they actually delist that firm and it's under private control. There is no public reporting on the financial performance of the target firm. There's also no transparency for entities that are outside of the deal, and that includes regulators, researchers, customers, any stakeholders who are sort of interested in how the target firm is doing until there's some legal action. And this transparency, unfortunately, or the lack of transparency, unfortunately, also sometimes extends to ownership. Oftentimes, it's not exactly clear who owns how much of a stake in the target firm. And I'll expound more on that when I talk a little bit on the next slide about how they generate profits from these deals. The second word is equity. Well, equity really relates to the source of the capital that's used to acquire the stake in the target firm. And for this, I'll have to explain a little bit on how this all plays out. So private equity firms are typically organized as partnerships. These partners, who are sometimes also called general partners, they approach investors to ask them for money or funds, which they're going to apply to a specific fund. The fund that they try to raise money for usually has a targeted purpose. So, it could be a sector specific purpose, like let's say healthcare, or even more narrow than that, like healthcare tech. They may also have a size focus. So there could be different ways in which these funds could be targeted, but that's usually how they organize them. and then they appropriately approach investors who are interested in those sectors. Who are these investors? Well, these investors are sort of a variety of groups, typically large institutions like pension fund managers, endowments, sovereign wealth funds, and sometimes even wealthy individuals. For example, some of the largest investors in private equity funds actually are the California Public Employees Pension Fund Managers, CalPERS, and also the Pennsylvania Public School Teachers Pension Fund Manager. So the PE firm gets money from these investors. That's the source of their capital or equity. They then combine it with lots of debt that they raise from lenders, banks typically, and they use this corpus of money to acquire a controlling stake or controlling stakes in the firms that they're interested in investing in. So this is a key aspect of private equity. They acquire controlling stakes. They don't just take a small stake in a target. They actually want to control that firm. And this is a distinctive characteristic of private equity. Uh, they usually have a very limited time horizon as far as this controlling stake is concerned. They look to sell this stake either to another private equity firm or by listing the firm on the stock exchange. They have various ways of what they call exiting the stake. And usually this happens within 5 to 8 years from the time that they invest. How do they make money? Well, they have three revenue streams. One is they get a small share of their revenue from what is called annual management fees, which they take from the funds that they raised from these outside investors. That's usually about 1 to 2% of the total corpus of capital that was committed by the investors. And you can think of it as, that's the money that they take for the job of identifying targets, investing in them, managing those investments, etc. The biggest part of their revenue comes from their share of profits that they receive when they sell their stake. So from the so-called exit, usually they get about 20% of the profits. For some reason, this is known as carried interest. I'm not entirely sure why. I'm sure there's some legacy reasons. And you probably heard a lot of debate about carried interest and the carried interest loophole. And I believe Erin's going to talk a lot more about that. And then the third source of their revenue is so-called monitoring fees, which they take from the target firm. So the target firm, for the privilege of being managed by a private equity entity, they have to pay the private equity owner a monitoring fees. This is also usually a small amount. The vast majority of their revenue comes from their share of the profits when they exit. Next slide, please. Okay, so how do they make money? The literature has sort of thought about this in three ways. The most important way is financial engineering. The single most critical aspect of private equity financing or private equity control of these targets is the fact that they use a lot of debt. 60 to 90% of the deal value is financed using debt. And that's one reason why these acquisitions were historically known as leveraged buyouts, where leverage denotes the debt. In fact, I sometimes joke that private equity should actually be called private debt because debt is by far the more important component. This debt, interestingly, is not placed on the balance sheet of the private equity fund. It's placed on the balance sheet of the target firm. So imagine that the private equity firm acquires a stake in a hospital or a nursing home. They actually put all that debt which they use to buy the nursing home on the balance sheet of the nursing home itself, which is quite interesting. The use of debt is very important in terms of profitability for the deal because it reduces tax liability, obviously, because interest payments are sheltered from tax. And then it also increases return on equity because it reduces the amount of capital that's required to actually finance a transaction. So you can actually go out and buy more firms with the same amount of money because you're using all this debt to finance the transaction. So this was the initial innovation or ingenuity in private equity when it first started in the 80s. Over the last couple of decades, they've added a couple of more financial engineering tools. So one is that they also target firms which have real estate, and then when they acquire these firms, they actually unlock the value of the real estate, so to speak, by actually hiving off the real estate ownership from the operational part of the company and then selling that real estate. And they try to do this fairly quickly. Within a couple of years of their ownership of the firm, they'll separate the real estate and sell it off. The sale of this real estate, which is called sale leaseback sometimes, it unlocks the capital even before they formally sell their stake in that target. And another recent thing that's sort of another example of financial engineering is the so-called dividend recapitalization. I know it's a complex word. All it means is after they acquire the firm, they go out and try to get more debt, which they can put on the balance sheet of the target firm to unlock some of the capital that they invested. And how do they do that is once they get that debt, instead of using that debt to improve the operations of the firm, they use that debt actually to get paid themselves in the form of dividends. So this is the financial engineering, which in my view is the core of the private equity playbook. But then in addition to this, they do some other things as well. There's this so-called governance engineering. And what that means really is that they change the leadership of the target firm. They bring in people who they have more faith in, who they think are more expert in running firms the way they want them to be run. They rejig the governance board. Oftentimes the partners of the private equity firm are now placed as directors on the board of the target. And most importantly, they change the performance incentives of the leadership team of the target so that they're more responsive to aspects that the private equity firm cares about. And finally, there's operations engineering, which is a more recent addition to the toolkit. At the end of the day, they will get a higher value from their sale of the stake if they increase the firm's profits. So how do you increase profits? Well, you reduce cost and you increase revenue. Jane and Zirui will talk a lot more about this in the healthcare context. I'll just give some high-level points. On the cost side, they are known to cut staff. In healthcare context, staff is a very big component. They also realize scale efficiencies, typically on the procurement side. On the revenue side, they do all the usual things that you could imagine. They renegotiate the prices with insurers so they can get higher prices. They try to increase patient volume using some referral techniques. They increase treatment intensity by doing more complex procedures. And sometimes, they can also indulge in things like upcoding. But this is really just a high-level view. Jane and Zirui will talk a lot more about this. Next slide, please. So I've given you an overview, and you might still be wondering, well, this sounds not that different than conventional for-profit ownership. Don't we always think for-profits are somewhat evil, and maybe they shouldn't be in healthcare? So it is true that for-profits are profit motivated, and that's been a very, very old debate in economics, and particularly in health economics. But even relative to conventional for-profit organization, private equity is a little bit different. And I think it really comes down to 3 points. The first point is this financial engineering aspect of how debt is used. Debt is a big part of the deal acquisition, and it's placed on the balance sheet of the target. So now the target has to pay interest and repay this debt, right? There's little capital infusion into the target in order to improve its own operations. If you compare that or contrast that to what usually happens in a regular acquisition, obviously debt does play a role, but that debt is not necessarily placed only on the balance sheet of the target. It's usually on the combined entity's balance sheet, and therefore it's the joint responsibility of the combined entity to repay that loan. So debt plays a very important role in distinguishing private equity from how these types of deals are financed in other types of for-profits. The second aspect is the short-termness. So private equity firms, they make most of their money when they sell their stake. And so exiting is very, very critical to making a profit from the deal. And they usually have to do it in 5 to 7 years. And that makes them prioritize certain things to increase value from the deal. Like I mentioned, the sale of real estate, that's one way to do it quickly. Another way to do it quickly is to cut staff. There are some things you can do quickly, and there are other things that require time. And the way private equity is organized, they tend to focus on the things that can happen quickly. In contrast, as a going concern, a for-profit doesn't necessarily need to exit to make a big payoff from their investment in a firm. And so that changes their priorities. And the third part is this moral hazard. Private equity firms can do well even if the target firm suffers. We've now seen multiple examples, even in healthcare itself, and many more outside of healthcare, where the target firm often goes into bankruptcy, but the private equity fund itself, actually did quite well on the deal. And this happens for a variety of reasons. Debt, as I've already said, because the debt was placed on the target's balance sheet, not on the private equity firm's balance sheet. So it's the target's responsibility to pay that back. Secondly, if there are any losses, the losses for the private equity firm are limited to its own equity investments, which tend to be quite minimal. And then the third one is in terms of reputation loss, somehow there's a minimal hit to reputation loss. We've now had pretty celebrated examples of bankruptcy for some of the largest private equity firms. It doesn't really seem to affect their reputation because for some reason it's seen as it's par for the course in this industry or in this business that some of these deals will go sour. On the other hand, when you think about a regular for-profit, let's say, a regular investor, the fortunes of the investor are quite intertwined with the fortunes of the target. And this is particularly even more so if the target happens to be listed on the stock exchange because there's a lot of public reporting that's involved, there's a lot of liability that's involved because of regulators. And so there, I think this moral hazard aspect is mitigated. Next slide, please. Okay, so now that we have some understanding of what private equity is, I'll just give a couple of facts. So one fact is that private equity investment in healthcare has grown very dramatically in the last decade. It was relatively flat in 2000 through 2010. There was an uptick in 5 and 6, 7, but then again with the Great Recession, things dampened down. But it's been almost monotonically increasing over the last decade, peaking in 2021 and now in 2022 with the overall economic outlook becoming a little bit less rosy, the number of deals and also the value committed has dropped. So it peaked in 2021 at about $100 billion of investment across the healthcare sector with about 1,400 deals. Next slide, please. And the investments of private equity firms in healthcare has increased disproportionately to the increase overall in the economy. So this figure is showing, pretty much the same sort of numbers, but overall, investment across all sectors in the US. This is for a shorter time horizon, but you can see that it's much more muted. And as a consequence of this, the share of healthcare of private equity, both deal value as well as number of deals, has increased from 2012 about 5% to about 10 to 12% in 2021. In 2022, it dropped again a little bit, but still higher than the 5% that it was in 2012. Next slide, please. So why is private equity investment grown so rapidly? Well, there's both supply and demand side factors, right? So on the supply side, there's cheap debt. Whenever there's cheap debt, it really fuels private equity acquisitions because they're so debt reliant. Policies have become more favorable over the last couple of decades, where corporate practice of medicine laws have been relaxed. Antitrust scrutiny is somewhat limited, and Erin will talk more about this. For lack of a better word, there are macro factors. Healthcare is seen as being recession-proof. We're an aging society, so healthcare seems to have, good growth potential. The government is heavily involved. There's great political will behind this. And then there's, of course, some micro factors like consumers are relatively inelastic in terms of they're not very sensitive to both quality as well as prices because insurance is a very integral part of this. On the demand side, at the end of the day, providers and other segments within healthcare, they want capital. They need capital to grow and to defend themselves in a competitive environment. And private equity offers another source of capital. And private equity firms are also very nimble. Next slide, please. And I'll actually skip this one in the interest of time. and I'll move to my last slide just to close things out, which is all of this is well and good, but why should we care about private equity investment in healthcare? In fact, the evidence from other sectors is actually quite positive. They lead to growth, they lead to improvement in efficiency. But we have to remember that healthcare markets have some uniquely dysfunctional features. Quality is very difficult to observe. And as a consequence, consumers don't punish poor quality providers. The market doesn't punish poor quality providers as much as it should. Consumers are relatively insensitive. They don't observe quality as much, and they don't pay on the margin. So they're relatively insensitive to price. The government plays a huge role, and government prices are fixed. They're not necessarily responsive to quality. And then the markets for some services are concentrated, and in general, there are big entry barriers. So I'll leave it there. I think I ran 1 minute over time, but hopefully this is a good segue for Zirui and Jane.
Great. Thank you so much, Dr. Gupta, for setting the stage for this conversation and outlining the recent growth trends in private equity. Next, we will hear from Dr. Jane Zhu, Assistant Professor of Medicine at the Oregon Health and Science University, and Dr. Zirui Song, Associate Professor of Healthcare Policy and Medicine at Harvard Medical School and Massachusetts General Hospital. Dr. Zhu and Dr. Song have published extensively on private equity. We are so grateful they are both with us today to share their perspectives and research. Zirui, I will pass it over to you first.
Thank you, Kate, and my gratitude to Jane and Erin and Atul for making this session possible and doing this all together. Building on what Atul said, I first want to sketch out for all of you the classic model of a private equity acquisition. This, in diagram form, on the next slide, captures a lot of what Atul has walked us through. First, you see a PE firm with a general partner, denoted the GP, creating what is called a PE fund. The private equity fund is a pot of dollars. In this fund, next, classically, you'll have about 30% of it comprised of equity. Those are the dollars that the PE firm has contributed, as well as the dollars that limited partners, largely in the US pension funds, university endowments, sovereign funds, and the wealth of wealthy people have contributed. The split is typically 2% equity in the classic model from the PE firm and 98% from these outside or limited partners. The rest of the PE fund, next, is comprised of debt. As Atul noted, the debt typically comes from some lender. Think of a bank. Next, the totality of the equity and the debt is used to acquire, in our setting today, a hospital or a physician practice or a nursing home, and the assets, the physical infrastructure and assets of that acquired entity is used as collateral for that debt. Next. The green arrows here denote for you the movement of dollars and returns. And the basic takeaway here is that the private equity firm has 3 streams of revenue, which Atul had talked about. And you see here that there are 2 types of management fees, one coming from the acquired entity, another coming from the limited partners, and the rest coming after the sale of the acquired entity. Now, typically in the classic model, when you look at 30% debt that's comprised of 2% equity from the PE firm and 98% from limited partners, that typically means that the private equity firm has less than 1%, specifically 0.6% in this case, of actual equity of its own in the entire private equity fund. The limited partners get some returns, typically the first 8%, call that the hurdle. And after the hurdle, they'll get a large share of the subsequent returns, while the PE firm also gets a substantial share of the subsequent returns. And the bank, the lender, gets a return from a fixed rate for the loan. Next. Finally, the acquired entity is typically sold within 3, 7, 5, 9 years, something of that order of magnitude. And as Jane will show you as well, there are 3 typical types of exit strategies in healthcare, either going public in an IPO, selling to a secondary private equity firm, or to another corporate entity, which I'll leave to Jane. Next slide, please. The evidence on hospital acquisitions in the US basically is around several hundred hospitals that have been largely acquired from roughly 2000 through the 2010 range. This is a very rough range. And on this map is a study from 2020 using 2018 data that shows you the locations of private equity acquired hospitals. Next. When we study these hospitals relative to matched control hospitals in the blue line here, with the private equity hospitals in the orange line, this study with colleagues Joe Bruch and Suhas Gandhi in 2020 basically looks at a number of economic outcomes and a couple of quality measures. This is a representative economic outcome that shows you 3 years prior and 3 years after a private equity acquisition, where previous to the acquisition, the charge to cost ratio of these private equity hospitals was rather similar and moved along a rather parallel path relative to the matched control hospitals. But after private equity acquisition, they began to diverge. The charge to cost ratio began to grow differentially relative to the matched control hospitals. On the next slide, you'll see in numbers form the other outcomes that follow the similar pattern. Net income grows by 27% after acquisition. The total charge per inpatient day grows by 7%. The emergency department charge to cost ratio grows by 16%. The graph you just saw, the total charge to cost ratio grows by about 7%. The case mix, a composition of patient morbidity or coding intensity, grows by about 1%. And the share of patients from Medicare declines, while the share from Medicaid stays about the same, implying that the share of patients who are commercially insured also grows. Next slide. In the literature so far, we don't have a whole lot of evidence on quality of care. This is a composition or a compilation of roughly 8 publicly reported HEDIS type quality measures, comprising 3 clinical entities here, among which there were mixed results. Heart failure quality measures, AMI quality measures for heart attacks, and pneumonia quality measures gave us a rather mixed sense of whether private equity acquisition potentially improves or makes quality of care worse. In this case, without going into the details, the Hospital Corporation of America 2006 acquisition of many hospitals within the HCA family had a lot to do with the average result here. When you pull the HCA cohort out of the data, the results look quite different. So for the average private equity acquisition that was not in the HCA family, the results on quality were quite muted. Next slide. In current work in progress, we are exploring this element of quality of care in more depth. I apologize for the spacing here within the box, but the graph here on the left shows that hospital-acquired conditions, as defined by CMS in a composite fashion, differentially increased among private equity acquired hospitals relative to their matched controls in the blue. So the red line begins below the blue line, meaning that private equity hospitals before acquisition had a quality of care level that was had a hospital-acquired conditions or adverse event level below their matched controls. But after private equity acquisition, they worked themselves to a level above the matched controls. This 25% increase in composite hospital-acquired conditions was driven by a 23% increase in falls, a 41% increase in central line-associated bloodstream infections, and a 5% increase in sepsis mortality that was just among patients with sepsis. Not included in here was also a rather sizable increase in surgical site infections, despite the fact that fewer surgeries were being done at private equity hospitals after acquisition. That result, though, was a little less statistically precise than the ones shown here. There were other results on mortality that are quite mixed, which in the interest of time, I'll skip over. Next slide. And in another version of this work, we examined mortality during the early phases of COVID, both COVID mortality and mortality among patients without COVID, who are hospitalized in the Medicare population. The basic takeaway here was that among patients hospitalized with COVID during the early phases of COVID, private equity hospitals demonstrated a higher mortality rate on average of about 2.3%, 2.3 percentage points higher relative to their non-private equity matched controls. For non-COVID patients, however, which there was a pre-intervention period for, we saw a differential increase in 30-day mortality among patients in Medicare hospitalized for all other conditions outside of COVID in the private equity hospitals relative to their matched controls. This is shown here by the orange line basically being parallel and on top of the gray line, which is the control hospitals before COVID and soon after COVID, working itself to above the gray line. Next slide. Next slide. Thank you. Our colleagues at Cornell have done some great work on nursing homes, as has Atul, and I'll just quickly summarize here by saying that when you look at the map of nursing home acquisitions across the different years here on the left, and think about comparing those nursing homes acquired relative to their match controls, we basically learned that there's been a sizable increase in ED visits, hospitalizations, and Medicare spending relative to controls, suggesting that the quality of care in these PE acquired nursing homes has differentially declined. Next slide. And finally, to quickly summarize Atul's excellent work here in the NBER, we found that, we learned through Atul's work that mortality in nursing homes among patients admitted to nursing homes differentially increased by about 10% within 90 days, and that societal spending has increased by also about 11% relative to the counterfactual. Next slide. In this rather concerning finding, Atul and his colleagues have found that the staffing, which Atul talked about a bit, has been thinner after private equity acquisitions. Specifically, nursing assistants has declined. And in addition, the overall patient rating or rating of the nursing home has also declined relative to control. So I'll wrap up here and pass it to Jane.
Jane, are you still with us? We'll give her one moment, otherwise we can hop over to Erin and then circle back if needed. Jane, is that you?
Yes, can you hear me?
Yeah, we can hear you.
Thanks. I'm having a little bit of trouble with my clicker right now. Just give me a second while I put my camera on, but in the meantime, I can just get started.
Sure.
Okay. Well, first of all, thanks so much for NIHCM for hosting this webinar. I am really grateful to the Foundation for sponsoring research on this important topic, and just want to give a shout out to the attendees. It's so nice to see a webinar this well attended, and it tells just sort of how I think interesting this topic is to many people. So I'm going to talk a little bit about private equity's activity in the physician practice space. I'm still trying to get my camera on. But let me see if I can get it on in a second. This is essentially saying that, similar to what Zirui showed with hospitals and nursing homes, we're really seeing hotspots of private equity acquisitions of physician practices in Arizona, in Texas, and Florida, parts of the Northeast, as you can see on this graph. This was a study that was led by a colleague of ours, Yashaswini Singh, across 6 different office-based specialties. We find some areas with virtually no PE acquisitions, which is shown in the gray here. And in some areas, we see that PE acquisitions surpass 1/3 of practices in a given specialty. Next slide. So there's considerable variation by specialty that we're seeing. In gastroenterology, for example, about 14% of office-based physicians now work for a PE-owned practice, compared to about 10% in dermatology and 3% in orthopedics. And I think this variable penetration by specialty really underlies PE's reliance on what we call a first mover advantage. PE often enters a market that's quite fragmented. They consolidate really quickly within a region or within a specialty, and then they move on to the next specialty, the next market. And so earlier PE activity took place in hospital-based specialties. For example, anesthesia, radiology has moved on since to higher volume procedural specialties like the one seen here. And then the current frontier is really in primary care, and in particular in risk-bearing entities that are participating in value-based payment. Next slide. In many states, there's actually these corporate practice of medicine restrictions, and they actually bar lay entities, corporations, from outright owning a physician practice, and this has historical roots. So to get around that structure, a typical transaction for a PE firm might look like this. Essentially, a PE firm will set up a management services organization to, in principle, provide back-end administrative and billing services, and then the PE firm will install a friendly, quote unquote, friendly physician who on paper owns the practice but is also simultaneously employed by the management services organization, or MSO. And then the PE firm acquires all of the non-clinical assets. Dr. Gupta already talked about, the real estate. They can acquire the medical equipment, the non-clinical staffing, supplies, and in exchange, to align financial incentives, in some cases, the employed physicians often retain an equity position in the form of company stock. And with that corporate structure, the PE firm is able to implement a roll-up or buy and build strategy. And that means simply that the PE buys a platform practice, one that often is well performing financially, but perhaps undervalued or can do even better, one that has good market reach. It might have an expanded geographic footprint, a good clinical reputation, and perhaps multiple physicians and clinical sites already. And then it will start adding or rolling up smaller practices to this platform. And it does so for a few reasons. Next, please. I think there's an animation. So first, larger practices can leverage greater economies of scale. So we have more cost savings, more efficient production. Larger practices can capture larger market share, of course, which then translates into market power, which favors these practices when they negotiate terms with insurers. And then for reasons that both Zirui and Atul talked about, it also means cheaper debt in the form of bank loans, which helps the PE company finance, obviously, more acquisitions. And then finally, the larger the practice, the greater the revenues, such that an eventual sale brings in higher valuation multiples. Next slide. So next slide. What does the evidence show in terms of PE's effects on physician practices? In a study published last year, we evaluated the effects of PE acquisitions in dermatology, ophthalmology, and GI. This figure shows on the x-axis the quarter relative to acquisition. The y-axis is change in total spending per practice relative to control practices. We see a visible trend upwards. And in fact, we find that relative to control practices, PE acquisitions increased average charges by 20%, average prices by 11%, aggregate volume of encounters by 16%, unique patients by 26%, and new patient visits by 38%. But at the same time, encounters coded as long visits greater than 30 minutes also increased. And since we limited our analysis to the same set of physicians that were present through all study years, it leaves one to wonder how exactly these physicians are seeing more patients, more visits for longer periods of time. Next slide. In another study that is currently under review, we're looking at changes in care delivery among retina practices that are acquired by PE. So in retina, there's a group of high-cost injectable medications that are used very frequently, as much as monthly, to treat common diseases like macular degeneration and diabetic retinopathy. And what's interesting here is that there are a number of essentially substitutable medications, obviously with some clinical exceptions. So the Medicare allowable reimbursement for aflibercept, Eylea, for example, is about $1,800. The same for bevacizumab or Avastin is about $100 per dose. And what we find is that after PE acquisition, spending on aflibercept increases by 21%. And that translates into an extra $250,000 per practice per year of just Medicare spending. Next slide. It's important to note that not all studies have found such large effect sizes. Another study by Robert Braun and his colleagues looked at PE acquisitions in dermatology. Shockingly, you'll see on this map that there are some markets in which a majority of claims, commercial claims, are actually from PE employed physicians. But they found in that study, in fact, that prices paid to PE dermatologists for routine medical visits were just 3 to 5% higher than for non-PE dermatologists, and they did not find any significant changes on spending or use of specific procedures. Next slide. I'll just share two more sort of notable studies. Amber LaForgia, who's currently at Berkeley, Haas, and her colleagues examined what happens when outpatient facilities contract with physician staffing companies in anesthesia, and these are often PE-backed. And this plays a large role in the delivery of anesthesia care. The 8 largest anesthesia-focused physician staffing companies, for example, they employ about 1/4 of all anesthesiologists in the US. So these are actually very common arrangements. And the authors basically tested whether outcomes were different for PE-backed physician management companies compared to both control facilities and facilities that contract with non-PE physician staffing companies. And just the takeaway from these figures is that there is a differential change in multiple outcomes. So allowed amounts, unit price, the probability that a practitioner becomes out of network, and that's differentially higher for facilities that contract with PE-backed staffing companies compared to all other physician management companies and to control facilities. So there is something unique about what PE is doing here. Next slide. And the same author looks at what happens when OBGYN practices contract with management services organizations that are explicitly different in their priorities. So in panel A, for example, when an OBGYN practice is acquired by a management company that's focused on clinical performance or quality, we don't see any changes in unnecessary C-sections. And perhaps it even trends downwards. But in panel C, when an OBGYN practice is acquired by a management company focused on financial performance, the unnecessary C-sections actually go up. And I think these findings really have important implications about how we think about PE, which as Atul and Zirui both talked about, are uniquely focused on extracting these high financial returns. And so a couple of concluding notes. Next slide, please. As Zirui noted earlier, PE is really just a brief layover in a practice's trajectory. Next button, please. Among the provider organizations that are sold to PE, about 65% are bought out by other PE firms, about 20% are sold to other corporations like Optum, and about 5 to 10% go public. I think there's 2 key implications here. One is that physicians who are looking to sell their practices may be able to vet their PE investor, they may be able to retain board seats and equity with the first sale, but the further out you look, the more that control is dilated. And then we often talk about PE in isolation, but the fact is that Optum now is the largest physician employer in the US, and PE relies on the presence of an eventual buyer that allows it to exit their investments successfully. And I think we ought to be keeping an eye on that dark gray box. So I'll stop here and transfer over to Erin, and I again apologize for my camera mishap.
No worries. Thank you so much, Zirui and Jane, for sharing the recent research and impacts of private equity and leaving us with some really clear takeaways. Next, we'll hear from Dr. Erin Fuse-Brown, the Catherine C. Henson Professor of Law and Director of the Center of Law, Health, and Society at Georgia State University College of Law. Her research focuses on healthcare markets, consolidation, and cost control. Erin?
Great, thanks, Kate, and thanks to NIHCM and my co-panelists for putting together this fascinating webinar. And we are all coming at it from different angles, and so I'm going to bring sort of the legal lens to wrap up our presentations. Next slide. So one of the sort of zooming back out, what can we possibly do now that we've seen the trends that Atul laid out of private equity investment in healthcare, and then some of the early research emerging about some of the effects on healthcare quality, outcomes, access, staffing, that Zirui and Jane have been, really did a great job summarizing, but also there's just like a whole body of work that's emerging on these topics. And I think the takeaway here is it's concerning, right? Private equity poses some unique threats and some maybe heightened threats to the healthcare environment, both in terms of cost and spending, but also in terms of quality outcomes. And the and the experience that clinicians have practicing medicine when they actually go through a PE acquisition. What is their practice experience like when it comes to their own professional satisfaction? So one of the premises that, when my colleagues and I have looked at this issue is to think of private equity, if we're trying to think of, well, what are the policy levers that we can apply to this issue, is to think of private equity almost as a divining rod to find market failures and payment loopholes. Because private equity investors are particularly adept at identifying and exploiting healthcare market dysfunctions in the form of payment loopholes or market failures. And they use this ability to find, we use them as a way to signal what are the sentinel pockets of money that are sitting out there. If you notice, not every single type of physician practice specialty is equally targeted by private equity. So why are they looking at particular specialties and not others? What is the revenue playbook, drilling down even further into the specifics? For example, that Jane illustrated with the ophthalmology example is that they have identified a market loophole there in terms of the Medicare Part B injectable drug reimbursement policy. So identifying what the specific revenue playbook in any given healthcare specialty will help us point to whatever the policy loophole, payment loophole, or policy market failure exists, it's being exploited for revenue, then I guess the policy response would be, well, let's close that loophole. That's at least one of the first policy responses. So there isn't, I'm just going to say it now, there's not going to be a silver bullet, but what there is sort of a series of identifying loopholes and attempting in a policy response to close those loopholes. All right, next slide. So I'm just going to go through these a little bit quickly, but again, they're just sort of doing that exercise of when we think about these different types of buckets of specialties, then we can identify what the revenue playbook is, and then what the policy response should be. So for example, as Jane mentioned, the early private equity entry into physician practices was based on the hospital-based specialties. These are the types of specialties where the patient doesn't choose their emergency room doctor, their anesthesiologist. And so the policy loophole here, the payment loophole, was to exploit the possibility for out-of-network surprise medical billing. Because the patient doesn't choose these providers and the payers can't steer patients to in-network providers, there really is no volume loss if an emergency department, a group of emergency room physicians decides just to stay out of network and bill higher out-of-network rates and balance bill for almost every patient they see come through the ED, even if the hospital is in network. So that was a revenue strategy identified by private equity investors. And I guess one could wonder, well, why wasn't this fully exploited to the max before? And I think that there are some sort of professional norms that prevent physicians from doing, again, extracting the maximum amount of profit from a possible billing situation, as opposed to, an investor who has a short-term return as their goal. So the threat of surprise billing, of course, also increases the rates when you eventually do contract for in-network providers. And this strategy was the revenue playbook. Of course, then the policy response is to end surprise medical bills, which we saw several states do, dozens of states do, and then finally the No Surprises Act of 2020 at the federal level that closed this payment loophole. And I guess the footnote to that is one of the biggest private equity-backed emergency room staffing companies, Envision Healthcare, a little less than a month ago declared bankruptcy. And so I think that was almost a direct response to the changed revenue environment. If you close their payment loophole, you close their revenue strategy, and they're declaring bankruptcy. Of course, KKR, their private equity owner, is doing just fine. It's not, as Atul pointed out, it's not necessarily, it doesn't go all the way up to the private equity owner in terms of the reputational hit. Next slide. So the playbook for the office-based procedural specialties that Jane was discussing, like the dermatology, ophthalmology, gastroenterology, those seem to be the types of physician practices that have not typically and historically been attractive to hospital and health system purchasers. So these are practices that are seeking capital investment, they're seeking investors, but they're predominantly procedural in the sense that they do a lot of in-office procedures, a lot of outpatient procedures, a lot of fee-for-service reimbursement. They're not always just sort of on a value-based payment. There's also a steady commercial as well as Medicare revenue stream, as well as potentially even cash revenue for optional procedures, think of LASIK or cosmetic dermatology. In addition, a lot of these types of specialties have the possibility of doing what are called wraparound services. So in addition to just the office visit, the practice can also bill for additional services, whether it's a physician-administered drug, whether it's pathology lab services or physical therapy, that there are additional services that they can keep within the practice and bill for if they can capture those referrals. So the strategy here is to increase the volume of patients, increase the volume of procedures and the intensity of the procedures that are done, keep them in-house within the practice, and also, as Jane and others have alluded to, reduce the staffing levels. So the same number of physicians might be seeing a greater volume of patients, many of whom are seen by mid-level practitioners. Next slide. So the playbook for value-based primary care type practices, which is I think the current cutting edge of a lot of PE activity, is again to build on the market share, use this platform and roll-up strategy to find must-have, well-positioned practices that have strong Medicare Advantage participation, for example, or also just have a good presence in the value-based payment ecosystem, and then partner with the payers, whether it's literally financially partner with the payers or eventually sell to a payer-backed physician organization to create a vertically integrated payvider. So that's a payer and physician practice conglomerate. And so what this allows the combined entity to do is to aggressively use coding strategies, particularly risk-based coding, on diagnoses of the patients or the Medicare beneficiaries, which are then used directly to increase the payment, the per patient payment, for example, under the Medicare Advantage system, but also under a variety of value-based purchasing arrangements. So the strategy here is to grow the Medicare population, the Medicare Advantage population, maximize that budget, and then reduce costs with utilization management. All right, so now I'm going to go on to the next slide, to the policy levers. So if these are the playbooks, then what are the policy levers? The first one is just to close the loopholes that we find are being exploited. So for example, the No Surprises Act was a good example of closing. Makes it sound easy. It was not easy, but it was an example of closing the surprise billing loophole. So what are the other ones? So another one would be to change the Medicare Part B payment system for physician-administered drugs to close the 6% sort of arbitrage loophole that the ophthalmology practices are being pressured to use, for example. Another would be to, again, increase Medicare Advantage coding intensity adjustment to increase recoupment of overpayments of the Medicare Advantage system to get at that sort of coding game that a lot of the primary care acquired physicians are now engaged in. So I think that it's not, again, it's not satisfying. It has a feel of whack-a-mole, but if you identify a payment loophole, I think one of the most direct routes is to close that loophole. All right, next slide. And then another would be antitrust enforcement. A lot of the results here in terms of costs and spending are the result of market power, increasing the market power of these physician practices. The problem is a lot of physician practice acquisitions, even some smaller hospital acquisitions and certainly nursing home acquisitions, are so small that they are not in dollar value, that they're not reported to the federal antitrust enforcement authorities. Right now, the Hart-Scott-Rodino Act reporting threshold is $111.4 million per transaction. So you can imagine a lot of these just don't even get reported at all because they fall below that threshold. In addition, the current antitrust authorities at the federal level are very reluctant to challenge vertical, meaning like payer physician or hospital physician or other types of transactions that aren't just a traditional hospital buying its neighbor hospital in the same market. So there's just sort of a lack of FTC and DOJ oversight in these spaces. And in addition, there are some things that the federal government could do. It could change the reporting threshold. It could allow the sort of accumulation of practices to sort of trigger reporting at a certain point, or just start to increase the scrutiny of these other types of non-horizontal transactions. In addition, states can play a role here as well by supplementing the antitrust. They have parallel antitrust enforcement authority, and some states are expanding their oversight over these smaller deals. All right, next slide. Another is to increase fraud and abuse enforcement. So fraud and abuse sort of gets at the overcoding, upcoding, improper staffing levels, and those types of behaviors that can be used for revenue can look like fraud and abuse when it comes to federal payers. So increasing fraud and abuse enforcement by looking very carefully at the way these arrangements are structured. The private equity firms, because they have a controlling stake, are very deep pockets that are often very knowledgeable about, and in fact at the steering wheel of the practice and coding patterns of the clinical acquired entities. So there could be a potential for significant fraud and abuse liability running all the way up to the private equity owner if they were to be probed and investigated by whistleblowers or by the government. Next slide. And then there are some levers that states in particular could pull as well. And these you heard mentioned the corporate practice of medicine, and there are other types of other state laws that could be strengthened to address, in particular, private equity investment in physician practices. So one is to let me start with the corporate practice of medicine. I think in some ways that's the biggest one. So the corporate practice of medicine, as Jane alluded to, is a historic doctrine that exists in just about every state. It's pretty weak. It's under-enforced. It hasn't really played a role in the practice of medicine in a long time in most places. However, most states have a law in the books that does prohibit or at least limit the ability of lay entities in controlling, employing, and owning physician practices. So there are ways that hospitals, for example, have gotten around this, and traditional other corporate investors have contracted around this. So states could try to, again, close that loophole, that contracting loophole, to try to make it a little tougher to simply contract around the corporate practice of medicine doctrine. They could do so statutorily. For example, there are a couple bills in recent memory from states like California that have tried to do that have not passed, but it would be, I think, a significant way for states to exert some oversight and leave the control not only of clinical decisions but also business decisions in the hands of the licensed physicians, not the private equity backed manager. There are other things that could be done in terms of non-competes, gag clauses, non-disparagement agreements, but I'll sort of leave it at that. There are just a bunch of different employment laws and other things that could protect physicians from the control of the private equity owner. Oh, so we are at time. I'm just going to advance one more slide just to show that there are some levers that can be targeted to PE itself. One is to close the carried interest loophole that Atul referenced, and this is a popular provision that seems to make its appearance most recently in the Inflation Reduction Act. Didn't pass. It was removed at the last minute to guarantee its passage. And then the other is to increase the transparency of ownership in healthcare. And there's a current bill that's being debated or discussed from the House Energy and Commerce Committee that would do just this. All right, so I'll leave it at that, and I'll open it up to some questions.
Great, thank you so much, Erin. I would like to try to get in one question, so if our other panelists can come back on video, that would be fantastic. So we've had a few questions come in around why private equity investment is attractive to providers and provider groups. What is the rationale for nursing home hospital physician groups in accepting this funding, particularly when there might be some of these negative impacts? And I'll open that up to whoever would like to answer.
Jane, do you want to take a first shot? I'm happy to follow you.
Go for it, Zirui.
All right, well, maybe on behalf of Jane, I think from our work, we would probably conclude that at times, provider practices look to private equity funding as much as private equity firms look to acquire provider practices, especially for some of our older generation providers in the delivery system. The private equity firms can give them a fairly healthy financial package. You can think of it as a buyout potentially in the earlier parts of the deal that gives them a fairly attractive or smoother path towards potential retirement or leaving medicine or scaling down from medicine. That is not to be discounted as a reason for the growth in private equity acquisitions on the physician side.
Great, thank you so much. And I know we are almost out of time. If we have time for just one more, how was private equity impacted by the COVID-19 pandemic? Can anyone speak specifically to that? Timing.
Well, a quick answer. I'm sorry to speak again, given my colleagues here. Several of our students had worked on this question, and we had a paper maybe a couple of years ago suggesting or sort of hypothesizing that because fee-for-service revenue had a nosedive during the earlier phases of the pandemic, and many practices were sort of on the edges of potentially having to close, that private capital, private equity included, might be a source of rescue for those practices. And so we were thinking that there may be an acceleration of private equity buyouts of stressed practices during the earlier years of COVID. I must say, empirically, I'm not sure that's actually materialized, and it's probably hard to separate from the secular trend of private equity acquisitions anyways, but that was at least a thought earlier on.
Great, thank you. And unfortunately, we are out of time. We've had a lot of questions come in, which we will just pass along to our presenters. I would like to thank our excellent panel of speakers. You did excellent with your presentations. Really appreciate you sharing your valuable work and perspectives with all of us. And thank you to our audience for joining us today. There is a survey that will pop up on your screen, and we really appreciate everyone's feedback. We also have other resources available on our website, including some of the resources that our panelists discussed. Just really appreciate everyone joining us today. Thank you so much.
Thank you, Kate.
Bye, everyone. Thank you so much.